This episode of the Nurse Practitioner Podcast is sponsored by Dakin's. When you're treating persistent, hard-to-heal, or complex wounds, you need a solution you can trust, like Dakin's Wound Cleanser. Just how powerful is it? Dakin's Wound Cleanser has been proven to kill even highly resistant bacteria like MRSA and VRE within only 30 seconds. It's non-cytotoxic, shelf-stable for 2 years, and more cost-effective than other wound cleanser brands. When you need a solution you can count on, ask for Dakin's. Before we start this 50th episode of the Nurse Practitioner Podcast, we wanted to take the time to thank our listeners from all around the world. We appreciate your support over these last few years, and we look forward to bringing you more great content from knowledgeable NPs and other healthcare professionals. Please note that the individuals who bring you this podcast do not have a clinical background, but we wanted to provide this medium as an added bonus to the Nurse Practitioner Journal. We hope you take away something good from each of our episodes, and we would love it if you could give us a 5-star rating on iTunes. As always, thanks for tuning in, and here's to the next 50 episodes. In this episode of the Nurse Practitioner Podcast, Dr. Julia Rogers and Dr. Alycia Bischof will be providing an overview of the important coding changes that will take effect January 1st, 2023. Information will be provided on important changes that NPs need to be aware of, so billing and coding is accurate for maximum reimbursement. Dr. Rogers will provide updates on inpatient coding changes, and Dr. Bischof will provide the important changes made regarding ambulatory care.
As a recap, in 2021, the American Medical Association revised the outpatient evaluation and management codes. The number of history and physical exam components required to bill at a certain level were eliminated. However, each encounter continues to require a medically appropriate history and/or examination. The final code selection is now based on either medical decision-making or total time. In 2023, we will see these changes carried over to the rest of the E&M codes. So essentially, now all of the E&M codes will share the same set of documentation guidelines with 4 levels of medical decision-making, either straightforward, low, moderate, or high. The amount of required time for each level will vary depending on the type of service. To adjust for the needs of more acute patients in the inpatient setting, a few additions were made to the 2021 medical decision-making table. Under the problems addressed component, 1 stable acute illness and 1 acute uncomplicated illness or injury requiring hospitalization or observation level of care were added to the low complexity level. Under the risk component, decision regarding hospitalization or escalation of hospital level of care and parenteral controlled substances were added to the high complexity level. Dr. Rogers will now give us some insight into the specific changes that we will see in the inpatient codes.
Can you discuss the latest EM introductory guidelines related to hospital inpatient and observation care services?
Sure. These evaluation and management codes replace the previous observation CPT codes, which were 99217 through 99220 and 99224 through 99226. The new codes to use for initial evaluation and encounter are 99221, 99222, and 99223. For the subsequent encounters, we are using 99231, 99232, and 99233. Finally, the discharge codes are 99238 and 99239, all of which require a medically appropriate history and/or examination with at least a straightforward or low-level medical decision-making. However, when the provider is using total time on the date of the initial encounter for code selection, then at least 40 minutes must be met or exceeded up to 89 minutes. If the encounter is 90 minutes or longer, then use the prolonged service code 993X0. 99231, 99232, and 99233 are codes that are associated with the subsequent hospital inpatient or observation care. These codes still require the appropriate documentation and a minimum of a straightforward or low-level medical decision-making. Next would be moderate medical decision-making all the way up to a maximum of high-level decision-making. If using total time on the date of the encounter for code selection, then 25 minutes is the minimal amount of time that can be met to bill code 99231. If the time exceeds 65 minutes or more, then the prolonged service code 993X0 is used. Coding for hospital inpatient or observation discharge is straightforward. The code 99238 is used if the discharge time was 30 minutes or less on the date of the encounter, and 99239 is used for a discharge time exceeding 30 minutes on the date of the encounter. Time includes the review of medical records, assessment and time with the patient, as well as documenting the discharge summary. It is important to note that codes 99238 and 99239 are to be used only by one provider, the provider who is responsible for the discharge services. The services provided by other physicians or qualified healthcare professionals that may also include instructions to the patient or family or caregiver, as well as the coordination of post-discharge services, should be reported with subsequent encounter codes previously discussed, those being 99231, 99232, and 99233. Also remember that for hospital inpatient or observation care, including the admission and discharge of the patient on the same date, use codes 99234, 99235, 99236, but not the discharge codes of 99238 or 99239.
What revision changes have been made to the inpatient consultation EM codes?
The inpatient or observation consultation codes 99252 through 99255 have also been updated. These codes are used for new or established patients and have the same requirements for documentation as the hospital inpatient and observation codes, meaning there still needs to be documentation of medical appropriate history and examination with a minimum of straightforward medical decision-making. When using the total time on the date of encounter for code selection, 35 minutes must be met or exceeded up to 94 minutes. But if the time exceeds 94 minutes, then use the billing code 993X0, which is the prolonged service code.
Can you explain the new guidelines that will take effect for shared split billing based on time for inpatient care?
The guidelines that were set to be implemented for 2023 are now on hold, at least until 2024. The Centers for Medicare and Medicaid Services has delayed implementation related to the narrow definition of substantive as it relates to shared or split encounters. A shared or split visit is defined as a visit in which a physician and other healthcare professional both provide the face-to-face and non-face-to-face work as it relates to the visit. When time is being used to select the appropriate level of services, for which time-based reporting of shared split visits is allowed, the time personally spent by the physician and other healthcare professional assessing and managing and counseling, educating, and communicating results to either the patient, the family, or caregiver on the date of the encounter is summed to define total time. The rule that was being considered would require the billing provider to spend more than 50% of the time on the facility-based split shared patient encounter.
Have there been changes made to the emergency department services EM codes?
Yes, while the existing CPT code numbers have been maintained, there have been editorial revisions to the code descriptors to reflect a linear progression of medical decision-making similar to the past changes of the E&M codes of outpatient office visits. Time has not been a criterion for code level selection in the past in the emergency department, and that principle has been maintained, simply meaning that time is not a component for E&M services in the emergency department. The codes 99282 through 99284 can be used by physicians and qualified healthcare providers other than just the emergency department staff. Critical care time can also be reported in addition to emergency department services if there has been a clinical change. Code 99281 will not be discussed here, as it is now considered a staff supervision code and may not require the presence of a physician or qualified healthcare provider in order to bill. 99282 is now straightforward medical decision-making. As it was in the past, this was considered low. 99283 is now low medical decision-making, and a 99284 is moderate medical decision-making. Whereas in the past, a 99283 and 99284 were considered moderate. And finally, a 99285 has not changed and is still being used for high medical decision-making. Keep in mind that all of these codes still require a medically appropriate history examination to be performed as well as documented.
What are the changes that have been made to skilled nursing facilities?
The code previously used for the annual nursing facility assessment, 99318, has been deleted. This existing service will now be reported through the subsequent nursing facility care services, 99307 through 99310, or via Medicare G codes. It is imperative to identify the role of the provider performing the service by using correct modifiers. Two major subcategories of nursing facility services are recognized: the initial nursing facility care and subsequent nursing facility care. Both subcategories apply to new or established patients, and both were also revised. The level of decision-making for nursing facility services is determined by the number and complexity of problems addressed at the time of the encounter, just as it is for other E&M codes and services. Initial nursing facility care codes 99304, 99305, and 99306 can only be used once per admission, per provider, regardless of the length of stay. They may be used for the initial comprehensive visit performed by the principal provider, also known as the attending. Nursing facility initial visits can be billed by a physician or qualified healthcare provider. However, skilled nursing facility initial comprehensive visits must be performed by a physician. 99304 through 99306 are similar to other codes regarding medical decision-making, meaning the lowest code, 99304, is for straightforward or low level of medical decision-making, and the highest code, 99306, is used for high level of medical decision-making. If using total time on the date of the encounter for code selection, then 25 minutes must be met or exceeded beginning with code 99304, and then up to 59 minutes with code 99306. If the encounter is 60 minutes or more, then the prolonged service code is 993X0. When completing a subsequent nursing care facility visit, for the evaluation and management of a patient, the provider must document the required medically appropriate history and examination. The codes 99307 through 99310 follow the same guide as the initial facility codes, with code 99307 used for straightforward or low level of medical decision-making, up to code 99310 that is billed for high level of medical decision-making. When using total time on the date of the encounter for code selection, then 10 minutes must be met or exceeded up to 59 minutes. If the threshold of 60 minutes is met, then use the prolonged service code 993X0. Code selection for discharge from a nursing facility is similar to that of an inpatient discharge and based on total time on the date of discharge management face-to-face encounter. 99315 is used when the discharge is 30 minutes or less total time, and 99316 is used when discharge is more than 30 minutes on the date of the encounter. Again, worth noting is that when nurse practitioners are working with physicians, they are considered as working in the exact same specialty and subspecialty as the physician.
Now we'll move on to ambulatory care and home or residence service codes. What changes will we see for patients cared for in their homes or assisted living facilities?
Well, first off, the labels will change. No longer will we use the terms domiciliary or rest home, so those codes 99334 to 99340 will be deleted. Instead, the term homes or residence will include all care delivered in a place where the patient is residing. Home includes permanent or temporary residence, hotels, cruise ships, assisted living, group homes, or residential substance abuse facilities. The EM code for this category are 99341 to 99350, excluding 99343, which will be deleted as the revision will make it a duplicate code. This will leave us with 4 levels of new patient and 4 levels for established patients. Of note, if you choose to code these visits using time, you cannot include your travel time.
What changes will we see with outpatient consult codes?
Similar to the inpatient consult codes, the first level code 99241 will be deleted, leaving us with 4 coding levels, 99242 to 99245. CMS still does not recognize consult codes, so we cannot use these codes for our Medicare patients.
How will visits be coded that exceed the highest code time limit?
99417 was introduced with the 2021 guidelines for prolonged services for outpatient visits on the date of service. In 2023, this code will also be extended to home and resident visits and outpatient consults. This code is billed once the time of the visit exceeds the highest level of the primary service by 15 minutes. It is an add-on code, so it must be billed along with the highest code, 99205 or 99215 for outpatient visits, 99245 for consults, 99345 or 99350 for home services, or 99483 for cognitive assessments. Codes 99354 and 99355, which currently are used for prolonged services except for outpatient services, will be eliminated. 99358 and 99359 should be used for prolonged services in these settings that occur on the day other than the day of the visit. 99358 is for the first hour, and 99359 is for each additional 30 minutes. 99415 and 99416 should be used for visits with a non-physician or qualified healthcare professional. Psychiatry has indicated that they do not need a prolonged service code, so 99417 cannot be added to the psychotherapy codes 90833, 90836, or 90838. CMS does not recognize code 99417. Rather, they have chosen to use G2212. They have also proposed making codes 99358 and 99359 invalid.
What billing options are available for nurse practitioners in the outpatient setting?
Nurse practitioners can bill 3 different ways, either direct billing, incident to, or split shared. Whenever possible, NPs should bill insurance companies directly under their own name using their own NPI number. The problem with direct billing is that Medicare and consequently many of the commercial insurance companies will only reimburse the practice at 85% of the physician rate if the visit is billed by the nurse practitioner. The advantages of direct billing are that the nurse practitioner can practice under the full scope of practice, as well as take credit for the visits and the care they provided. If incident to billing is used, the practice receives 100% reimbursement. The disadvantage of billing incident to is that certain rules must be followed, such as the physician must be in the office suite at the time of the visit, and the NP cannot see any new patients or new problems. Also, only the physician's name appears on the billing, thus making the NP a ghost provider. With split share billing, the visit is billed under the provider that spent the greater amount of time or completed the substantive component of the visit. If it is the physician, the visit is reimbursed at 100%. If it is the NP, it is reimbursed at 85%.
When can we bill incident to versus split shared?
Incident to billing can be used in place of service 11 only. Place of service 11 is the office setting. It cannot be used in any other outpatient setting, including a facility setting. And place of service 19 is off-campus outpatient hospital, and place of service 22 is on-campus outpatient hospital. It is important to know what type of facility you work in. These days, many practices have been bought by hospital systems. If care is delivered in an outpatient facility that is owned by a hospital, whether it is attached to the hospital or at another location, then billing needs to be direct or split shared, not incident to. As Dr. Rogers stated earlier, split share billing will continue using the rules instituted in 2022 for 2023. Look for the rules to change in 2024 when it is proposed that split share billing will use only time and drop the subsidizing component for the visit option.
Nurse practitioners have a responsibility to be competent in regulations related to coding and billing services, and to ensure services rendered are coded and billed appropriately. Since state regulations vary, changes made to CPT codes may affect NPs differently. In 2021, the CPT code set changes to outpatient visit, evaluation, and management services were the most significant for NPs. Overall, there were 329 changes from the previous year, with 206 new codes, 69 revisions, and 54 deletions. Then, in 2022, the CPT code set had 405 editorial changes, including 249 new codes, 63 deletions, and 93 revisions. In the upcoming year, 2023, the CPT code set will have 393 editorial changes, including 225 new codes, 75 deletions, and 93 revisions. While all of them cannot be discussed here today, you can review all of the changes and deletions being implemented in 2023 by reviewing the CPT Evaluation and Management Code and Guideline changes.
Thanks to Dr. Julia Rogers and Dr. Alycia Bischof for taking the time to chat with us today. For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, updates, and much more. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks for listening.